the APHSN um, webinar series. So this is the third session for our June edition of the webinar series. And today we'll be having um, Hilda Okafor as our facilitator, and she's going to be talking about a very important topic that is a very important topic. I'm sorry. Yeah, so she's going to be talking about a very important topic, which is design thinking in healthcare, and it's very important to learn about this as a growing innovator or as somebody that is just interested in digital health. So, like I said, we're having Ida Okafor, and I'll just take a short moment to read her bio. So Ida Okafor is a licensed physiotherapist and digital health advocate who seamlessly bridges the gap between clinical realities and technology through design thinking. With a of Physiotherapy from the University of Ibadan, she identified early on that effective healthcare requires more than medical knowledge, it requires intuitive user-centric tools. This realization led her into product design, where she now leverages her where she now leverages over 4 years of experience crafting solutions across multiple industries, including health, travel tech, cloud, social networking, SMEs, and AI. Understanding that impactful design must be paired with sustainable business models, Hilda completed the Venture in Management program, mini MBA, at Lagos Business School through Junior Achievements Nigeria. This rigorous training equipped her with the strategic leadership and business acumen required to scale healthcare innovations effectively across emerging markets. As a testament to her impact in the ecosystem, Hilda was a candidate in the United Nations Development Programme (UNDP) Digital for Youth-led Enterprise Programme, where her and her team won first place in the health track. She is currently applying her expertise to build Raycare, a digital workspace product focused on enhancing patient engagement and adherence to home rehabilitation programs. An award-winning speaker, workshop facilitator, and the author of Healthscape UX newsletter, Hilda actively shares her insights on digital rehabilitation and UX strategy. She is deeply committed to empowering the next generation of healthcare professionals to explore tech-driven career paths and utilize design thinking to solve complex clinical challenges. Please, um, we need the virtual claps. Please just like clap as we welcome Hilda Okafor onto our mini virtual space. Thank you, Ma. You can have the floor.
Hi, thank you so much. Thank you so much for having me. Hi, everyone. Good evening. Good evening, everyone. Hope we are all good and hope our weekend went well, going on well. I would say. All right. So I'll be sharing my screen. So I'll be speaking on design thinking in healthcare.
Hi, Moa. You can stop sharing your screen so that we can see the facilitator screen.
Okay. Miss Guys, can you all see my screen, please? Okay. Thank you so much for having me. So I'll be talking about design thinking in healthcare. So first off, I would want to talk about design thinking first without bringing healthcare into place because we are going to like add that as we go by. So design thinking is solving problems by starting with the people who have them. So I would say design thinking is a framework of solving a problem. And we have different frameworks actually. And design thinking is one of them and one of the most popularly used framework in solving problem. And I'll say design thinking is not only for healthcare, it goes across board, across areas of life. We can apply it to everything we are doing, every little thing we are doing, right? It might just define which we qualify each of those stages. So now we have 5 stages of design thinking. We have empathize, define, ideate, prototype, and iterate. So these 5 processes is very important, and design thinking is in cycle because when we get to the point of iteration, we are going back to empathize because everything that you are trying to solve, you need to also review it. So let's start with empathize. So to empathize means to be in the shoes of the people you are trying to solve that problem for, to be in the shoes of the people having those problems, so understanding their lived experience, and now bringing it into healthcare. As a healthcare professional, you can you can have so much of that experience firsthand, even while as a clinical student in the clinic or probably at your workplace or internship, you can have some of those problems. Okay, probably you are doing your internship or house job, or probably you are going to the clinic and you experience one or two things. You are in the lived experience. You're experiencing what other healthcare professionals are experiencing. And that is what it means to empathize, to to be in the shoes of those people that are having those problems. So we now move to define. This helps to frame the real problem your from the way you empathize. So I'll come back to empathize now. So empathize is living in the shoes of those people, trying to know what their problem is, recreate that problem so that you see how the problem is. Number two is doing research, trying to talk to those people. You are doing research with those people, talk to them, send out surveys, try to know what it is that they are experiencing. So the research is very important. So when you come to define, all the information you've gotten or the data you've gotten from the research, the insights would help you to build a refined system in a way that you are able to write out your problem statements. So that's what defined does. It helps frame the real problem from the research insights. Then for ideas, it's from ideas. For ideas now comes from defining the problem. So from defining the problem, now you're looking for a series of ways to actually solve that problem. You're not just looking for one way. And again, I would like to say that in design thinking, um, you have to be open-minded. Yes, don't put any form of bias. because you don't know where the solution is yet. But the most important thing is getting to know the problem. Then you can now look for several ways to solve that problem. Then when you get several ways to solve this, can you hear me?
Yes, we can.
Okay. So anything, I don't know if you are following me.
We're following.
Okay, thank you so much. Okay. Okay, I think I lost my train of thought. Okay, yeah, I remember now. So in trying to, okay, for ideas now, you have to generate a wide range of creative solution. And from that, you are going to do that from the problem insights, the research insights you've gotten from the users, right? So now, in the process of ideating, you'd want to rule out any form of bias. You'd want to be open-minded because you are going to have series of solutions to solve that one problem. And having having listed series of solutions to solve the problem, you are going to choose the one that is most sustainable that you can someone can replicate that solution elsewhere, and it's not seemingly going to die down, and the users or the people you are solving that problem for are going to find it very useful and timely. So now moving to prototype. So you would want to, after you've brainstormed, you've chosen a pathway, you can quickly test that idea into solving the problem. So you build quick. And one of the best way to test a problem is using low costs means. You don't necessarily have to, I would say, okay, build an application because you want to solve the problem. You can use the most minimal method. It could be by, let's say, using WhatsApp to solve a problem, or probably talking to the people themselves to know the kind of flows they actually do from their day-to-day activities. Then after the prototype stage, you have to go back, give this prototype to users to test it for you because they are the ones that are going to use it. You don't test it on yourself and you don't build for yourself. You build for the people that you are empathizing with. Yeah. Then you give it to them, you test it, you get feedback, and you work on the feedback. On working on the feedback, you see that you're already coming back to empathize, you're redefining again, you're ideating, and you're going to prototype again. So design thinking is a cycle, it's a framework, and it's a cycle. Yeah. So why healthcare is a unique design environment. So healthcare is very delicate. So we have to be very careful in the way we use or solve problems. And so I would say one of the uniqueness is the risk and safety. Errors can happen and that can actually cost life. So every solution must be accounted for. Every solution must account for patient safety, the healthcare professional safety, and the healthcare system as a whole. Then another one is regulation. So if there are not regulations to put a check and balances to all the things that we are trying to innovate, most times things get out of hand. So design must comply with health regulations and data privacy law. Another one is complexity. So you don't want to involve yourself in so many things. We have like multiple stakeholders, fragmented system, and constrained resources. So um, you would not want to do so much at once, but pick it at one step at a time because the healthcare system is very complex. So you have to pick the most simplest version of the problem, not simplest version of the problem rather, but like just pick a fraction of the problem to solve because you can't solve everything in healthcare. So the healthcare system is a complex arena. So we have human factor. like we the users now, or the healthcare professionals, or public health specialists, or digital health specialists. So we bring in human factor in sense of stress, the workload that might actually affect the usability. So moving on to the next one, which is human-centered versus technology-centered design. For technology-centered design, it's most likely starts with solutions or technology. And most of the question you'll be asking is, what can this tool do for me? And most times it only fits users to the system. That is, you are not taking users in mind, but you are just building the technology and taking it to the user after. And sometimes it often leads to reduced adoption of these tools that you're trying to build. So that's how most times we have adoption issues in healthcare, implementation issues rather. And one of that is digital literacy, which is very important too. So if they are not technologically inclined, they might not be able to actually use a technology-centered device. And most times, this kind of method loses sight of actual care outcomes. So the best way is to go the human-centered way by asking people questions, by being in the shoes of those users. And you want to ask them, what do these users really need? What do they need? What is their pain points? How can we, what is it that you find discomforts in? So you'd want to ask them those questions. Then you build a system around those problems. That's where you ideate, you define and you ideate, right? Then you see that, okay, if you are actually building for these people in particular, there will be a readiness to actually use this tool. And yes, the readiness or the adoption might not come initially, but it's showing that you are actually keeping those users in mind. And I'll say users is king, just as customer is king. Yeah. So, and also it also leads to a better health outcome. So getting to know the people first is very important. So understanding users in healthcare systems. So what are we actually designing for, and what do they need? Okay, so who are the users? So for this slide, I just gave it like an example. So users can be anyone. Your primary users can actually be a patient or a caregiver. Your primary user can actually be a clinician. The primary user can actually be an administrator, depending on the kind of problem that you're trying to solve. But I am just using this as an example. So let's say for now, we have primary users as patients and caregivers. So I would like to say primary users interact directly with the solution, while secondary users are affected by or in support. They work hand in hand, right? So let's say for this example, patients navigating illness, fear and complex systems, right? Family caregivers managing medications, appointments, and care coordination. Now, looking at the secondary user, you know that patients navigating illness, the secondary user of that system would be the clinician, because probably you have two interface too, whereby the patient interacts with one, and by extension, the information the patient is needing is from the clinician via the device that you are using. So that's how you just connect them. Then another is administrators, scheduling and billing records. So if you are seeing this family caregivers managing medications, appointments, and care coordination, so you can actually link it to the administrators because they interact with the administrators. Yeah. So for mapping systems interaction across pathways. So for this slide, I'm going to explain how like I'd say on a normal condition, how the system between the patient, admin, and clinician works, and putting forth some actions at the top. And what handover gap can we see between them? So for symptom onsets, so patient searches symptom, oh, I have headache or something, or probably I have an outgrowth. Then this can actually lead them to self-diagnosis, and they decide whether to seek care or not. And probably they now got in touch with a platform and they call for appointments, right? So in that appointment, there could be a gap where no symptom context is passed to the system, right? So they are just booking appointments. Oh, just put your name, book appointments, but probably there's no input space for them to state a short note of what they are actually experiencing, so that even the clinician, before getting to them, they can know that, oh, I'm expecting this patient with so kind of complaints. That's another gap that might actually occur. Now, going into the same patient, they attend consultation, they arrive, check at the desk, wait in waiting room. That's like another gap, really, because they're going to wait again, right? And again, one of these gaps too can be because of the ratio of the healthcare professionals to the population, which is very, very low. So that could actually be one of the gap. Then receives diagnosis, that is after they've gotten there. They receive diagnosis, either verbal or paper. Paper can lost. Verbal, they might actually forget if it's a complex word, and that is a gap. Then they await follow-up, and there's no clear timeline given, because imagine you going to the hospital and they're telling you to come in the next 4 weeks, right? You might not be in loop of knowing what is going to happen next, even when you come in the next 4 weeks. So that is a gap. Patients can't act or plan on anything. They are just waiting for you, so that when they come the next 4 weeks, they can now solve the problem. So there are a lot of gaps if you are just looking at this normal routine. So now, looking at the admin, we have logs appointments, that is logs appointments from the patient's booking. They send SMS confirmation to patients, does not capture symptom detail, like I said. Clinician sees minimal detail, so they are unaware of what this patient is supposed to have. So this is basically what this chart is telling us. So you can actually just sit down one day and start brainstorming about one or two things. Go to the hospital and experience it yourself to see if actually these things actually happen. You talk to one or two people about it, and that is how you be in the shoes of the user. You empathize with them. So empathy mapping and patient experience design. So getting into the heads and hearts of the people we design for. So in building an empathy map, we capture what the users say, what they think, what they do, and what they feel. So what they say is like a direct quote. You just, like, probably you are having an interview or a conversation or a random conversation, and you just picked exact thing they said, and you're like, okay, oh, this could actually be something to take note of. Oh, I don't know what this medication is for. Nobody told me what to expect. That could be like an example, right? Then what they think, their internal, like, you just want to to observe how that whole situation was, their internal beliefs, even if it is not stated, you'd be able to determine. That's why most times it is advisable to talk to these people and not only surveys. So I see a lot of people bringing out surveys, but qualitative research gives you in-depth. In as much as qualitative research would give you like variety of some of these options that you should focus on, but having in-depth conversation with these people would actually take you somewhere. So you'll be able to see their countenance, the way they express this problem, and you would see their expression to know how painful it is, or if it is something that is what's solving, right? So for what the users does, you just want to observe their behavior and action. Research, so probably you are inside the clinic. So there's what we call observational research, whereby you can just go to the clinic and sit and watch everything happening, right, around there. That's a form of imputing this empathy. Probably when you are done observing, you can now go and ask them some questions and you can get your say, think, and feel from them, right? So you just want to know you just want to observe their behaviors and action around that problem arena that you're trying to ask or know more about. Then for the emotional state and worries, well, their expressions would also matter. And in one or two things in what they say would actually tell you that, oh, I know how this person feels or how he or she felt. And probably you are seeing the same train of thoughts in what they are thinking, and you can note them down. Then from some of these things, you can now bring out the pain points and what you think would be the gains for these users. So for the patient journey mapping, so you'd want to create like a journey map like this one that is here. So this is more like a journey map, but more of a system interaction between patient, admin, and clinician, right? So for this one, this is for the patients. So let's say symptom onset, of course, they are worries, and this is the emotion that they would get. They search for symptom online, they clear trigger guidance, right? Before they now move to booking appointments. Oh, I'm relieved a bit. Let me book an appointment. That's what this emoji is telling us about. That's what this emoji is telling us about. Then another thing that they might experience is long waits on phone and the digital booking tools. Probably they don't understand how to use it too, or probably they cannot even impute their symptom inside, but they just want to book. So that's like another way to look into it. So you just want to create a journey of what the users are supposed to do. So now in this way, we are not only focusing on patients. So for example, you want to build a system whereby public health specialists want to be able to see I would say surveillance, all this disease outbreak surveillance, like map, right? And you want to actually build something like that, let's say for the African setting. I think your user there will be the healthcare specialists too, or people that are actually working in monitoring and evaluation in public health. So you have to be specific to the user. So patient alone are not only the users. This is just like an example. Then they go into consultation and okay, they are feeling a bit relaxed, or or they forgot to save one or two things. So another thing that could happen is they forget key questions and the pre-consult prep tools too. They might not be able to actually understand it. And probably after the whole consultation, they, they were now more confused about the whole situation, right? And they can't actually process all of this information, even with written summaries and all. So now the next step, they are unsure of the next step, and they need a care navigation support. So all of these things now is opportunity. So searches symptom online. An opportunity for it is to clear triad guidance. That is, have a very good system that clears the triad, so that even when they come to the clinic, it's they are getting straight to what they want to do. They are not waiting any minutes or hour because of that. Another one is long waits on phone. Digital booking tools would solve that. Forget key questions, pre-consult prep tools. That's an opportunity. So what journey mapping does is once you've created the normal process that it should be, look into it again and see opportunities that could arise from this patient's experience, especially the emotions. No, can't process all info because we have written summaries. They will be able to get back to it. They are unsure of the next step, and that's why there's an opportunity for care navigation support. So that's why these processes are very important. So problem definition and framing. So a well-defined problem is already half solved. Yes. So in writing a problem statement, we have a formula for that. And the formula is the problem is that users in location have problem because of the root cause, right? So for problem statements, you just want to be on the problem rather. You just want to be on the problem. They're not looking for any form of solution, but be able to state that this is the problem that you are seeing. This is a problem that you've gotten from the research that you've done, or from the people you've spoken to, or from the surveys that you've gotten. So the problem is that, so an example is this: pregnant women in rural Kebbi states have high rates of preventable maternal deaths because, so the problem is that we did not start with the problem is that, but we're starting with the specific user in Kebbi states have high rates of preventable maternal deaths, which is the problem. Because what is the root cause? Because the nearest facility with a skilled birth attendant is hours away and many can't afford emergency support. And likewise, you can look at this second example: informal sector workers in Lagos, that is the users. So you can say the problem is that pregnant women in rural, the problem is that informal sector workers in Lagos and Kano have no health insurance coverage. This is the problem. This is the location. Because what is the cause of it? NHIS style schemes are built around formal employment, and most income earners fall outside that structure. So that's a way of framing your problem statement. And after you've framed the problem statement, the next thing that you'd want to do is to frame your how might we questions. So you've stated the problem clearly. Problem user to the problem and to the root cause of that problem, because you would want to solve from the root cause. Next month.
Hello everyone. It seems the facilitator is having some network issues. So let's just wait for a moment to allow her join the meeting back. While we wait, please start cooking up your questions and like any
I'm so sorry, that was network, so continue to share my screen now. Okay. Okay, so we stopped at the how might we question. So after framing your problem statement, you want to go into the how might we solve that problem. That's basically what it is. And what the how here does is to assume a solution exists. It's telling us that yes, it's not if we can, it's how. Then the might tells us here that keeps it open-ended and not how we will. It's not something that you've already had a preconceived solution in your head that I have this idea, I want to solve it. And one thing is, funny enough, you might not actually do it the way you were thinking, right? So if you are open-minded into listing out a lot of how might we questions and getting ideas to answering those questions, you would not be able to pick the most sustainable, the one that can be replicated and is most useful by the users, because you will still test, you still validate the answer with the users. So that is how that is what the how might we question does. It helps us to remove any form of bias and see through a lot of ways we can solve this problem. That is what the might. It's keeping it open ended and not a closed thing, not how we will, which implies you already have the answer. Do you get? So it is how might. Then the we signal a collaborative effort is not something of a personal burden or a single burden. It's something that is a collective effort whereby you also you brainstorm around among your team members and also with the users that you are trying to solve this problem for. So I'll give an example. So the example is based on this. The problem is that pregnant women in rural Kebbi states have high rates of preventable maternal death because the nearest facility with a skilled birth attendant is hours away and many can't afford emergency support. So now how might we? And here we have like different, so it's not something of one how might we questions. You could have 12 how might we questions, right? But for this for this um for this webinar, I had to put just 5. And you see that they are in context. So how might we bring skilled birth attendants closer to the pregnant women in remote villages so that they don't have to travel hours during an emergency? That's a proximity issue, right? How might we make emergency support affordable and reliable for rural pregnant women so that distance doesn't determine survival in case? So you're trying to be open-minded. You're not fixated on one. This one is about costs. Now, how might we equip local community health workers to recognize and respond to birth complications so that life-threatening delays are reduced before a skilled attendant is reached? So that's local capacity in the sense that you want to train them. That's another way to look into it. How might we help pregnant women in remote areas identify high pregnancies early so that they can plan to deliver near a facility before labor begins? This is prevention and timing. And this also involves awareness, education too. Now, how might we create a rapid response network between rural communities and nearest skilled facilities so that help can be mobilized the moment a complication arises, and that is coordination. So you would want to write a lot of, so for each of these questions, you could have like 10 solutions to it. When you brainstorm, you can now bring them close to 2 or 1 or the nearest one. And that same goes with the remaining questions. So it makes you to see a lot of things that could actually work that you might probably have missed. That's what the I might read question does, and helps you to choose the most sustainable. So common mistakes in healthcare solution design. So I put together 6 common mistakes. And the first one is no user research. You are going on vibes. You are going on what you think or what you feel, or you are going by what you see, not what you heard. Is not enough. So start with observation and interviews before any solution. Don't just build a solution. Talk to these people. Talk to these people. Healthcare system is delicate. Delicate. So you have to talk to the users, especially in a setting in Nigeria or in African setting. The African realities is very much different from the Western world. So you want to look at the problem that people are actually facing aside healthcare and how it interconnects. So research is very important. Now, ignoring clinician workload. If you are building something and it's like 4 steps to solving a problem, and you don't actually go to the clinic to see their processes, they are going to overlook whatever you built and continue with their manual processes. That's why I'll say that's why it's very difficult for healthcare professionals in the African setting to actually embrace some of these digital tools, right? Because some of them cannot actually use it. They feel it's a waste of time, and they just have so much comfort staying in that position. And also, we don't also want to ignore their workload. We want to look for ways to make their activities faster, ways to reduce their time from 30 to 10, from 30 minutes to 10 minutes. So you have to work with them, audit their clinical flows first. Adding more clicks reduces adoption. So they might not be able to embrace something like that. So perceived is different from validated. So you're not going on vibes, you're not going on assumption. You want to validate. So that's why after your how might we question, and you writing out the ideas for each ways, ideas on each way to solve any of these problems listed. Yeah. And you narrow it down to one. You take one from, let's say, from this proximity angle. You take one from it and you, you go and test that solution. You test it in the minimal way possible that you don't have to spend money on, and see if it works and it's something that people are willing to pay before you can now go ahead to do any form of um, big building or solution building like that. So test with real users early. Then ideal scenarios only. That's like another mistake. Like I said, in all of this, these are all ideal scenario. But inside that ideal scenario, there are problems inside. There are still problems inside. So we shouldn't overlook it and build only for ideal scenarios. And you know that the African problem is different from the Western problem. So we want to know all of these things. You want to design around under-resourced setting. You want to design around the real environment. You want to design around the real environment. You want to design around things like network or ways to solve that problem. Then the next one is no iteration. So not going back. And like I said, design thinking is a cycle, is a process, is a cycle. You have to go back again. Build fast, test fast, learn fast. One perfect prototype after 6 months is too late. So you have to test fast and implement fast, and also work on those problems fast. Give it to users, let them use it. They're the best people to actually give feedback, not your friend or your neighbor, the actual people having that problem. Then tech without process redesign. So technology should follow process change and not substitute it. So you shouldn't be so clouded on the technological aspect, but it should be a process for you and not an entire substitute for what you should do. And I'd like to end this with build with people, not just for them. That's the work. Build with people, not just for them. Build with people. Don't build for people, but build with them. Build with them. Let them even be in your team. And it is also advisable that healthcare professionals should embrace digital literacy or even the technological space, so that you bridge the gap between the typical technologist and the clinician. You are bridging that gap because you're already coming from a perspective of the clinical view, and you already have experience in the technological view. So you're already bridging that gap and you're building with the people and not just for them. Thank you.
Wow. Thank you so much for that amazing session. Like, I'm sure everyone has learned one or two things. Me, I have learned a lot. And wow, I think we can all agree that that session was amazing, and we've learned about the design thinking process, the importance of health empathy in healthcare, identify real problems and the common pitfalls in designing health solutions. And all we all had the take home message of build with people, not for them, like build with them, build along with the community. Now, we'll move on to the Q&A session. So if you have any questions, kindly drop them in the chat or raise your hand, and then we can go from there. Please, let's do it very quickly because our time is fast spent. Any questions? Anybody? Okay, it seems we don't have questions. But me, I have one question. But this question, okay, somebody, okay, Hassan Ismail. Um, please go ahead and unmute your mic and ask your question. Someone will raise their hand up now. Okay, as I was saying, I have a general question, ma. So my question is, for us students who are new to design thinking, what practical steps would you recommend we take after this webinar? Like,
Okay. So for practical steps, so that depends on what you actually want to do. So the first step is to immerse yourself into the process. You can just test it, see it as a project, just to actualize it. Oh, is there any problem that I've seen recently that I would really want to solve? Right.
mm,
You can now use that process to test run it and see it work in real time. And it does not necessarily have to be only in healthcare. It could be in different ways, right? So practical step is identify a problem, try to interview one person, just one person, right? Then ideate around it, brainstorm around it, do some of those problem statements. How might we brainstorm with people, have a session with people, ask them questions, put them down, and quickly build something. Now, with the in this AI age that we are in, you can actually build your solution fast. But the most important is to be sure that that problem exists. The problem exists, and you validated that the problem exists. And through validating the problem exists is by doing your research, confirming that through your research, and a very fast prototype to see that, oh, this can actually solve this problem. So it's something that you can do within. It's something you can do personally by yourself. Yeah.
all right, thank you so much, ma. I hope we've all heard. Find a problem and try to start applying what you've learned today. So, as we've come to the end of today's session, I'd like to sincerely thank our speaker and facilitator, Hida Okafor, for sharing our knowledge and experience with us. And I also want to thank everyone who has joined and participated actively. And we hope today's session has given you a new perspective on designing solutions that truly address healthcare needs. So this has been week 3 of ADHSN Digital Health webinar series, and we look forward to seeing you next week, Saturday by 6 p.m., where we would be talking about um, framing and user journey mapping with a new facilitator. All right, everyone. Until then, keep learning, keep connecting, and keep innovating. Have a wonderful evening, everyone. Thank you so much, Ma, for this session.
Thank you.
What? Abraham Moseri, do you have something to say?
No, I'm just saying thank you. Thank you.
Okay, okay. All right.